Well, it is exactly 4 o'clock. So, good afternoon and good morning to some of you from my home here in northern Montana. My name is Caitlin Conway, and I am a chronic disease and patient family engagement lead here at Mount Pacific Quality Health. We are very happy to see such great attendance at this very important event. During today's session, Uncontrolled Hypertension, the time to act is now, our team will be sharing information and insight into the effects that COVID-19 is having on hypertension. Before we begin, I would like to briefly introduce our two amazing speakers. Stevie Tsai started at Mountain Pacific in 2017. She currently works as a healthcare transformation account manager and leads projects in Wyoming that work to reduce adverse drug events. She works closely with various partners in the state, including the State Pharmacy Association, to share knowledge and increase participation from pharmacists and primary care providers in quality improvement projects that focus on medication safety. Stevie is a registered pharmacist and has 14 years of exceptional experience in pharmacy work. Joining Stevie today is Dr. Malter. He received his medical degree from Oregon Health Sciences University and did clinical training at the University of Colorado. Before moving to Alaska, Dr. Malter had a faculty appointment at the University of Washington School of Public Health, where he taught health policy and conducted studies in health services research. A board-certified internist, he is the former Medicaid medical director for the state of Alaska and former president of the Alaska State Medical Association. He has been with Mountain Pacific since 2016. Please join me in welcoming Stevie and Dr. Malter. Stevie, the floor is all yours.
Thank you, Caitlin, for that excellent introduction. And thank you, everybody, for taking time out of your busy day to meet with us and talk about hypertension in the time of COVID. Just some housekeeping for us. We do have some objectives. We're hoping that over the next 4-part session, so this is part 1, and then every 2 weeks we'd like to meet with you to continue our learning. We want to talk about COVID-19 related current events. We'll focus heavily on the Mountain Pacific area, so we'll talk about that region in a moment. We want to identify best practices for hypertension identification and management during the pandemic. And then we want to help people implement quality improvement projects to improve hypertension diagnosis and management during the pandemic. And we also want to engage and empower patients to foster continued health team participation. We do have, we do have a member of our Mountain Pacific Patient and Family Advisory Council. I would like to recognize Wanda Webb for being on the call with us. She is an excellent patient advocate and is here to help give that patient voice and perspective as we move forward and work to improve care. As I mentioned, Mountain Pacific Quality Health serves a 4-state area, Montana, Wyoming, Alaska, and Hawaii. And then we also serve the Pacific Island territories of the United States. So that includes American Samoa, Saipan, Guam. Saipan is part of the Northern Mariana Islands. So we have the privilege of working with individuals from a wide variety of areas, primarily with rural health concerns. So that is our area of focus here at Mountain Pacific. I'm going to dive right in the interest of time and talk a little bit about those areas and what is going on with COVID. So I have just some brief flashes up here. I did use primarily state or territory data for this. It tends to be more rapidly reported. That does mean that it hasn't been cleaned, so it is preliminary data. So this is subject to change. But we've got Alaska and Guam, Hawaii, Montana, the Northern Mariana Islands, and then Wyoming. And I went through those very rapidly because I really want to get to, when we talk about COVID-19, we tend to talk about cases and deaths as individual statistics, and that is powerful for our local information, but it doesn't necessarily always give us a lot of information about how we compare to other areas. So this graph here has information about COVID-19 in our areas per 100,000 people. So that was based on 2020 population estimates. Since the census isn't returned, there is some volatility in those numbers, but this gives you a rough snapshot of sort of what is happening. And I'd really like to point out here what is happening in Guam as far as their daily case. So this was from the 23rd. where they had 51.55 new cases per 100,000 people. So as you can imagine, that is a concern in Guam. That's a pretty big spike. It is driving up their active cases. Alaska has the most active cases in our area per 100,000. That's important because we all talk about the R0 of COVID. So its ability to transmit from person to person. If we have more active cases, in theory, we have more risk of transmission because that R0 does remain above 1, meaning for every person who gets sick, they can transmit to at least one additional person. And then we have our death rate, and this is where Montana is unfortunately leading the pack at 9.47 deaths per 100,000 people. These are pretty comparable with some of our national statistics. Those daily cases do go up in areas where we have increased risk of transmission, and we are seeing a wide geographical variability of the deaths as a result of COVID. As this is a new disease, we don't always know why that is occurring, but more evidence is being gathered every day. You will notice on here that I do not have American Samoa on here, and that is because they are the only geographical area in the United States that has not had a confirmed case of COVID. So they've conducted over 1,500 tests so far, but have no confirmed cases of coronavirus, in large part due because of their geographical isolation, but also because they quickly implemented really good protective programs that limited the risk of transmission to their area. So hopefully as we continue to go through this, we can share a little bit about how American Samoa was able to do that, because it has been truly incredible how that very small rural community has responded to coronavirus. As we move through this, please feel free to pop questions in chat. We'll also have a brief Q&A session at the end of this. We welcome your questions as we move through. So as we go through and we talk about COVID-19, we hear constantly that chronic conditions increase the risk of morbidity and mortality, so severity of illness and risk of death with COVID-19. And hypertension is one of those things that has sort of bubbled to the top. We'll talk a little bit about the findings in reports and studies as we move through today's presentation. But I just wanted to give some background about hypertension in the US. I want you to keep this in the back of your mind as we move through this. About 75 million Americans have hypertension. At least half of those do not have that condition under control. About 11 million of them don't even know they have high blood pressure. They may have had it mentioned in a visit. They may have heard it discussed with their provider, but they don't know that they could have a diagnosis of hypertension. And most of these folks that fall into that 11 million do have health insurance. They are accessing the healthcare system. And so we are missing the opportunity to talk to them a little bit more about their risk of hypertension. And not only does it cause concern during this time of the coronavirus pandemic, it also causes concern for our longevity of life. We know that hypertension causes a lot of end organ damage. It carries a lot of risk for other comorbidities. It's something that can really impact a person's quality of life. And we have many patients that we are missing opportunities with. When we talk about estimated hypertension prevalence, there are things that always happen, right? We diagnose those patients with hypertension where their BP is higher than 130/80, and we start talking to them about bringing them into care, right? And we have two sort of just options. We talk about lifestyle modification, which includes changing your diet, exercising more, reducing sodium, losing weight if you're overweight. And then we also can do lifestyle modifications because all of those things are needed, plus medication. And this particular graphic came from a 2016 study. And I just want to point out in the lifestyle modifications, those 100% of people who pick lifestyle modifications only will remain uncontrolled as we continue along the path of care. We also have a large chunk that pick medications that remain uncontrolled. About 71% of folks who start hypertensive medications will remain uncontrolled, so their BP will still be above goal. However, as we layer on, typically a hypertensive person requires 3 or more medications to really get a handle on that disease. And we bring more and more into the controlled area. There's still a lot we can do as clinicians and as patients to help get that blood pressure under control. There are a lot of factors that go into why people are uncontrolled, and we're hoping to work on that as we move through this 4-part series. As we move through identification and status, about half of our patient populations will go into treatment. They agree to develop goals and implement changes, whether that's taking medication or improved exercises, where we can call them treated. And then about half choose to remain untreated. So again, there's opportunity for us to really talk to patients about where they're at, what their concerns are, and why they aren't getting into treatment, considering medication, those sorts of things. With that background, I'm going to pass it over to my colleague, Dr. Alex Malter, who is going to talk a little bit about hypertension and COVID-19.
Okay, thanks so much, Stevie. And thanks, Caitlin, as well, for putting this together. And thanks to all the participants for wanting to join us. Mountain Pacific appreciates getting the chance to work with collaborators to help them think through ways of improving treatments, whether it's during times of a pandemic or just during regular times. We like doing this work, and we really appreciate everybody listening in, and hopefully we can help them. With that, as I get started, I'd like to point out that if folks find this presentation useful, be assured that it's mostly because the staff at Mountain Pacific have done a nice job putting together these slides so that they keep me on track, and they do a good job of keeping us all on the same page. I came on with Mountain Pacific 3 or 4 years ago, and I'm not a full expert on coronavirus, as my initial disclaimer. And my hunch is there may be some of the folks who are even participating and listening who know more certainly about certain aspects of this epidemic than the staff at Mountain Pacific do. So I'm looking forward to the questions and answer sessions when we can kind of hear from those of you who are in the field, or maybe some of you who are really expert in certain aspects of this, to kind of fill in any gaps. And there are a lot of gaps in this presentation, in as much as there's a lot that's not known about COVID-19, and that's coming out on almost a daily basis. Toward the end of the presentation, I'll give you some data which is just hot off the press in the last week, again, just to kind of show how things are moving so quickly. We know that as the epidemic started from China and New York, that folks who were being admitted to the hospital with COVID-19 had a disproportionately high prevalence of hypertension. This was seen in the province in China, about 50%, and I think the numbers were a little closer to 55% in some of the early New York studies. So on the surface, it would be easy to conclude, or want to conclude, that hypertension is a strong risk factor for having a more serious case of coronavirus. However, as a lot of you understand, you know, those simplistic kind of first degree, single variable analyses don't always account for kind of the complexities of these cases. And the question has been whether or not hypertension is, you know, strongly a predictive variable on its own, or whether it's really more of a marker of other illnesses which might have more of an impact on outcomes, such as shown here, obesity, diabetes, chronic kidney disease. Not shown on that table on the right is probably an even stronger predictor, which is age. And we'll come back to that in a few minutes. But as most of this group probably knows, hypertension is strongly correlated with age. As folks get older, they have higher rates of hypertension. And we'll see in a couple of slides that age is probably one of the strongest or the strongest predictor of how people do with coronavirus and the severity of their COVID-19 illness or even death. As Stevie pointed out, hypertension is very prevalent. With the old measures of hypertension that were in use until 3 or 4 years ago, the 140 is over 90 numbers, about a third of the adult population in the country would be diagnosed as hypertensive. With the newer recommended criteria, using a cutoff of 130 over 80 for stage 1 hypertension, the proportion really goes up closer to 50%. And that's, if you look at the slide prior when you're going back through this, that's consistent with those numbers that Stevie put up a few minutes ago. So essentially, half of the adults in the country using our new tighter criteria are hypertensive. I think most of this group knows that maybe other than smoking, hypertension is the commonest cause in the United States of premature death and disability. And folks also realize that treating hypertension is very, very effective in decreasing risk of subsequent cardiovascular events. Unfortunately, even using the old goal of 140 over 90, only about 50% of people reach their treatment goals. And when we use the no goals of 130 over 80, it's even a smaller proportion than was shown on that prior slide. Maybe whoever's clicking, could I get the next slide? Thanks so much. So we all see a lot of this data kind of flashing through even the lay press. I'm relying mostly on information from the CDC. And this is from an article guideline. I think we have it listed below, so you can pull it up if you want to. And it was most recently updated just a week or two ago. And it shows that from CDC data, there are certain illnesses which are clearly associated with increased risk of severe illness, which is getting hospitalized or put in the CCU, ICU, or death from COVID-19. Cancer was recently added. Chronic kidney disease has been recognized for many months now, COPD, obesity, and heart failure and cardiovascular disease. For those of you with good eyes, you'll see that sickle cell disease probably doesn't belong under heart failure, but it too is it's an illness which definitely increases the risk of a severe disease, as does type 2 diabetes. Next slide. Now, perhaps a little surprisingly, certain illnesses are not quite as clear-cut. It appears that there may be an increased risk in folks with asthma or previous strokes or cystic fibrosis and hypertension, which is what we're talking about today. But again, as discussed earlier, in as much as there's so much confounding of some of these illnesses with others, which might have stronger predictive values, it's not necessarily clear from multivariate analyses yet whether or not something like asthma or hypertension in our case is going to be an independent variable predictive of outcome, or whether it's really going to be a marker of, for example, age or kidney disease. Next slide. Okay, thanks. So this comes from a CDC report, and I think we're going to list it below if people wanted to pull it up. But this is a CDC slide showing that from a single variable standpoint, hypertension as a single variable seems to triple the risk of getting hospitalized with coronavirus compared to the rest of the population. Similar for diabetes, similar for obesity, a little higher for chronic kidney disease. And then when you start putting these together with multiple conditions, the risk goes up even higher. But then, as shown on the next slide, if I could get it, the biggest predictors are really, the biggest predictor is probably age. And here, hospitalization rates for the oldest folks, 13 times higher than comparison groups, death rates 600 times higher. So in as much as we talked earlier about how the prevalence of, or the prevalence of hypertension goes up with age, you can see that if age were really the only, even if it were the only predictor, that it might appear as if hypertension were playing an effect, even if it were mostly age. That being said, I think that my impression is that most of the researchers believe that these other factors are indeed playing a role. It's just that we've not been able to look at the data long enough and clearly enough to piece out the multiple variables. Next slide. So COVID-19 and hypertension, what we know and don't know. This is from the College of Cardiology, which, along with the nephrology groups, tend to be the owners of hypertension in this country. And this is an article which you could pull up, and it essentially talks about the fact that, that again, it might appear that hypertension is related to outcomes, but that the data are really not completely settled yet. It also talks at length about the fact that that coronavirus partly seems to pathologically, impact folks by binding on to certain ACE receptors. And most of you will recognize that that's that same ACE term that we think of in terms of ACE inhibitors. So there was a concern early on that that treatment with ACE inhibitors might have been upregulating these receptors that happen to be in certain key organs, the lungs and the heart, and might have been even increasing the risk of SARS severity. However, that seems to have been dispelled. And this article, for example, looks at the data pretty carefully, and the cardiologists and nephrologists have largely concluded that it's not a problem that folks are on ACE inhibitors or their ARB drugs, those classes of antihypertensives, that there's no evidence that being on either of those classes of medications really increases the severity of disease. And the upshot of this kind of opinion piece from the College of Cardiology is that folks should continue their blood pressure medications as recommended before coronavirus, and that in specific, they should not be stopping their ACE inhibitors or their ARB type medicines or probably their spironolactones despite this hypothetical pathophysiological issue having to do with ACE receptors. Next article, next slide. Okay, and this is mostly the same thing. Again, the Heart Association, like the American College of Cardiology, always does a nice job of kind of summarizing. And the upshot of their recommendations are that, yep, you just continue taking your medicines and working with your providers' offices, your physicians or your nurse practitioners, and you continue trying to optimize your blood pressure control. And again, this shows the 130/80 numbers that now we are pushing for. And it too also concludes that patients and providers should not be concerned about this this pathophysiological linkage with ACE2 inhibitors, but instead should continue using that class of medicines. I mean, one of the reasons that that's important is about half the patients being treated with meds in this country are on medicines which affect that renin angiotensin pathway, the ACE inhibitors and the ARBs. Next slide. This is from, so I had put together my slides. This is a shout out to other staff in the organization. I had put together my slides and my talk and had finished my literature review 4 or 5 days ago. And I thought I was set. And I got an email from staff showing this new study, which when I reviewed it, I think was quite well done. This was done by a group in the UK, and they did a very high quality meta-analysis looking at, in a case control fashion, looking at various studies which had tried to estimate the risk of problems of treating hypertension and with specific classes of drugs in terms of severity of illness and poor outcome. So there were hundreds of studies which had looked at outcomes and then in a case-controlled manner had looked back to determine which medications folks had been on. And the studies were often small, but when combined together in a meta-analytical fashion, these researchers were able to strongly conclude that, treatment for hypertension it certainly doesn't hurt outcomes, and that using ACE inhibitors and ARBs is not detrimental compared to using other drugs. And that in fact, for folks with hypertension who were going into the ICU, folks who had worse outcomes versus better outcomes, the folks who were on ARBs and ACE inhibitors tended to have better outcomes in this meta-analysis of case-controlled studies than folks who are on other classes of blood pressure medicine. So not only no reason to stop the medications, but maybe even a tiny bit of reason to think that in the future we'll see the ARBs and the ACE inhibitors will actually prove to be maybe even a little bit beneficial. But that's very preliminary. Certainly don't quote me on that. This has only been out briefly and it's not been thoroughly vetted. So I wouldn't make any clinical decisions based on that. But I think the article does make us feel reassured that at least with ACE inhibitors and ARBs are not apparently hurting people. Next slide. Oh, and I think that is it for me. I'll stick around, of course, for questions and answers. But otherwise, Stevie, I'll turn it back over to you.
Perfect. Thank you so much, Dr. Malter. That was very informative. It is nice to know that we don't have to change what we're doing in clinical practice right now, but like he said, the science is changing regularly. So we're hopeful that we can keep you up to date. If there's any retractions or anything like that that goes on, we will be sure and let you know. As we move forward in our series, the next piece we want to work on here in 2 weeks is really identifying our hypertensive patients and our patients that aren't at goal. So looking at establishing clinical criteria, maximizing our electronic health records so that we can find those patients, and then making a plan to get them to goal. And then also doing some quality improvement in the background where we can be data-driven and evidence-based, and giving you tools and resources on how we work toward that. So that's a little snapshot of what you can look forward to in the next 2 sessions. As Alex mentioned, we do have resources for you. Please check out these references. The CDC has a ton of resources. And as always, the American Heart Association and Million Hearts have just loads and loads of really excellent hypertensive treatment resources. With that, we have just a brief window of time. Feel free to stay on the line with us and we can take your questions now. If you do have any questions, please pop them in the chat and we are happy to answer them. You can also reach out to any of us via email or contact us at our website, which is mpqhf.org. All right, that brings us to our 4:30 close. We appreciate everyone attending. We appreciate your feedback as well, and we look forward to meeting with you all again in 2 weeks.